So, very good evening to you all. Hope you all are doing well. In today's session, we are going to discuss the question themes which have appeared in the last 2 years in the specialty certificate exam and the European board exam of endocrinology and diabetes. Now, basically, I've covered it in different parts. In each part, I've tried to cover around 10 to 15 question themes which have appeared in the previous exams. And therefore, of course, they are very high yield for the upcoming exam in this year. As you all know, in June, you will be appearing for the specialty exam, and in November, you'll be appearing for the European board exam. So let's start right away. So one of the question themes which had appeared in the previous exams was a typical history and biochemistry, which was suggestive of postpartum thyroiditis. And they had asked, what is the percentage for recurrence of postpartum thyroiditis in the future pregnancies? Let's look at the answer. So the correct answer is 25%. Now, this slide and the next slide are extremely important in terms of exams because many statements appear frequently in the exams from these two slides. So thyroid dysfunction usually occurs within the first 6 months postpartum. The prevalence of postpartum thyroiditis is around 5 to 10%. However, the postpartum thyroiditis can develop in up to 30 to 52% of the females who have got positive TPO antibodies or thyroid peroxidase antibodies. So having positive TPO increases the incidence of developing postpartum thyroiditis around 30 to 52%. Most patients have a complete remission, but some may progress to develop permanent hypothyroidism. It is 3 times more common. So postpartum thyroiditis is 3 times more common in women with type 1 diabetes mellitus. Of course, we looked at the recurrence percentage, which was asked in the exam. Permanent hypothyroidism can develop in up to 30% of women within first 10 years. In terms of clinical presentation, 32% can present with hyperthyroidism, whereas around 43% can present as hypothyroidism. Hyperthyroidism typically develops within 4 months of delivery, can present as fatigue, resolves spontaneously in 2 to 3 months, but can be followed up by hypothyroidism. So make sure that you check your thyroid function test every 4 to 6 weeks. In the meantime, beta blockers can be used to control the symptoms while the patient is in the thyrotoxic phase. Hypothyroidism, as I mentioned, 43% chance of development, develops 4 to 6 months after the delivery. Symptoms may be mild or non-specific. There is an increased risk of postpartum depression, very important statement. Treat with levothyroxine if TSH is more than 10, or even if TSH between 4 to 10 and symptomatic, treat with thyroxine. Need to check thyroid function test every 6 to 8 weeks, and then subsequently wean off thyroxine fluctuate. The scenario of hyperthyroidism followed by hypothyroidism can occur in 25% of the patients, whereas spontaneous recovery can occur in 80% within 6 to 12 months of delivery. All these statements taken from the Oxford Handbook of Endocrinology and Diabetes, 4th edition. Extremely important 2 slides, and many statements from this appear subsequently in European board as well as specialty exams and have appeared in the last 2 years as well. The second question theme is there was a history and biochemistry suggestive of polycystic ovarian syndrome, and they had asked that patients with PCOS had increased risk of which malignancy. So what's the correct answer? It's endometrial carcinoma. So in anovulatory females, endometrial stimulation by the unopposed estrogen can result in endometrial hyperplasia, and several studies have suggested that this can also result in 2 to 4-fold excess risk of endometrial carcinoma in females with PCOS. And that's why it is recommended to induce at least 3 to 4 withdrawal bleeds per year to reduce the risk in an amenorrheic female. What are the other risks associated with PCOS? Type 2 DM, 2 to 4 times more common in females with PCOS. Again, these statements very, very important, frequently appearing in the exams. Impaired glucose tolerance can affect 10 to 30% of the females with PCOS, and gestational diabetes is also more prevalent. Dyslipidemia can occur. In fact, several studies have suggested an increased risk of hypercholesteremia, hypertriglyceridemia, and low of the HDL in females with PCOS. Arterial disease, meta-analysis has suggested a twofold increased risk of arterial disease in females with PCOS compared to those without the PCOS. In terms of pregnancy outcomes, there is an increased risk of miscarriage by 2 to 3 times, increased risk of GDM, increased risk of hypertension by 3 to 4 times, and increased risk of having a LSCS compared to that of without PCOS. And all these statements are again taken from Oxford Handbook of Endocrinology and Diabetes, 4th edition. The question theme 3, there was a history mention of a typical type 2 diabetic patient, and scenario was given and asked about glycated albumin and over what duration does it estimate a blood sugar control. So glycated albumin, first of all, is a non-traditional marker of hyperglycemia. It is the proportion of albumin that is glycated, and the duration of glycemia reflected by it is over a period of 2 to 3 weeks, which was the answer for this question. It does not require a fasting state to be taken in the sample and can be measured in the serum or the plasma. In terms of limitations, we should keep in mind that it is affected by changes in albumin metabolism, and that's why we can get falsely low values in relation to the mean blood glucose values if there is a rapid serum protein turnover happening, as may occur in patients with protein-losing enteropathy or nephrotic syndrome. And that's why that can commonly affect the measurement of the glycated albumin, which we should keep in mind. Other things which can interfere is thyroid dysfunction and, of course, the method of performance of glycated albumin. What are the other non-traditional markers which we should know for your exams is fructosamine. Again, it is a total serum protein glycation. It reflects again duration of glycemia similar to the glycated albumin, again a period of 2 to 3 weeks. Again, it does not require fasting. Affected by change, it is again in serum protein metabolism, especially albumin, and also for cases of thyroid dysfunction. So pretty much how we have a falsely low value in the scenario of a protein-losing enteropathy or nephrotic syndrome with glycated albumin, same can be with fructosamine. Fructosamine values usually range between 266 to 312 millimole per liter, which is roughly equivalent to an HbA1c of 7%. What are the other non-traditional markers of hyperglycemia? There is 1,5-AG, which is basically 1,5-N-hydroglucitol. It is a monosaccharide filtered by the kidney, and it is normally reabsorbed. However, reabsorption is inhibited, and it is excreted at a high levels of glycemia, and so the serum levels start to drop, and that is what we can measure. It reflects the duration of glycemia over a period of 2 to 14 days. Okay. Again, it does not require fasting, can be measured in serum or plasma. It is affected by changes in renal threshold for glucose. So basically, an SGLT2 inhibitor can interfere with its measurement. It can be affected by dialysis or by stage 4 or 5 kidney disease patients, also in pregnancy. So during euglycemia, basically, 1,5-AG is filtered and completely reabsorbed by the kidney. So that's how it is reabsorbed by the kidneys. As a result, serum concentration levels of 1,5-AG usually remain stable. Now, what happens at a higher glycemia level? Renal reabsorption of 1,5-AG is completely inhibited by glucose. And within 24 hours of a rise in blood glucose to more than 180 milligram per deciliter, which is 10 millimole per liter, the renal threshold for glucose secretion falls as urinary losses starts to increase. So that's how the basic idea behind using 1,5-N-hydroglucitol as a non-traditional marker of the hyperglycemia. HbA1c, we all know about that. It is a proportion of a hemoglobin that is glycated. Duration of glycemia reflected is over a period of 2 to 3 months. It reflects 2 to 3 months control. Low within person variability as sustained. No patient preparation needed. No affected by the acute illnesses, stress, or recent activity levels. Again, limitations, it is affected by alterations in the red cell turnover. We'll look at it in the next slide. Some methods of measurement can give inaccurate results, especially in presence of hemoglobinopathies. So let's look at that slide which I was talking about. When HbA1c levels are unexpected or discordant with the other information, especially glucose values, the following factors should be considered. Number one, red cell turnover. Falsely high HbA1c values in relation to a mean blood glucose values can be obtained when red cell turnover is low, resulting in a disproportionate number of older red cells. This can occur especially in patients with vitamin B12 or folate deficiency anemia. So we'll get a falsely high HbA1c value even though the mean blood glucose levels are normal. On the other hand, rapid cell turnover leads to a greater proportion of younger red cells, and that's why it will falsely lower the A1C values. Examples of this scenario include patients of chronic hemolysis like thalassemia, G6PD deficiency, patients who are treated for iron or B12 or folate deficiency, and patients who are treated with erythropoietin. So again, a very important slide in context of your exams, mentioning about the factors which can affect the HbA1c estimation. Other things we should consider is HB variance. Depending upon the methodology, HbA1c can be altered. It can be high or low in patients with hemoglobin variance. CKD can also affect the A1c values. It may be altered in the setting of a CKD. Most of the inaccuracy in relation between HbA1c and mean blood glucose value occurs in the setting of an advanced CKD, those who are on dialysis and those who are on erythropoietin treatment. Decrease in measured A1c may occur with hemodialysis and altered red cell turnover, especially in the setting of erythropoietin, as we looked and in these particular slides. The question theme 4, which had also appeared in the previous exams in the last 2 years, was a typical case scenario was given of a female 18-year-old with Turner syndrome, and they had mentioned about the ASI. I will tell you what is an ASI, and I had mentioned the ASI to be 1.5 centimeter per meter square, and they had asked for the frequency of cardiac monitoring which we need to do in this patient. How often should we repeat the transthoracic echo and transthoracic echocardiography? So what is ASI? Basically, ASI is the aortic size index. It is the absolute aortic diameter in centimeters divided by the border surface area in meters squared. So these are the guidelines from the European Society of Endocrinology. Extremely important set of guidelines. Several questions keep appearing from these guidelines, and this particular chart is pertaining to the question theme which had appeared in the exam about the cardiac monitoring for women 16 years and older with Turner syndrome. So cardiology exam, TTE, cardiac MRI and ECG. So the scenario in our patient, she did not have coarctation of aorta, she did not have a bicuspid aortic wall, she did not have hypertension. In this scenario, if the ASI is less than or equal to 2 centimeter per meter square, in our patient it was 1.5 centimeter per meter square, then that is considered as low risk. And in this, the duration of repeating the TTE or the cardiac MRI is every 5 to 10 years by the cardiologist. So this was the answer, and this is the low risk category. On the other hand, if the ASI is between 2 to 2.3, that makes it moderate risk, and in this we have to repeat it between 3 to 5 years. On the other hand, if the ASI is more than 2.3 centimeters, that definitely is moderate risk, but at the same time, in this scenario, we have to repeat it every 1 year by the cardiologist. So more than 2.3 centimeters, still moderate risk, but because the size is more of the ASI, we need to repeat it every 1 year. On the other hand, if the patient had a coarctation of aorta or bicuspid aortic wall and or hypertension was present, then it becomes more complicated. In this scenario, even if ASI is less than or equal to 2.3 centimeters per meter square, moderate risk, and in this scenario, we should do the TT every 2 to 3 years. On the other hand, if it is more than 2.3 centimeters in the scenario of coarctation of aorta, bicuspid aortic wall, and or hypertension if they are present, then that becomes a very high risk. And in this scenario, we need to repeat the cardiac MRI every 6 months to 1 year by the cardiologist. So this is the suggested cardiac monitoring protocol for girls and women with Turner syndrome above 16 years of age, as published in the European Society of Endocrinology guidelines. So that's the end of the free view. I've covered another 8 questions in the full session, so around 12 questions in the full session of part 1. I'm planning to do subsequently other parts so that I can cover at least between 100 to 150 questions in this series of SCE and European Board Exam Reboot. Of course, the full video is available to my paid subscribers. So if you like to subscribe to my full lecture series, as you already know by now that there are a total of existing 55 videos in this lecture series. So once you subscribe to this lecture series, you'll get access to these 55 existing videos plus all my upcoming videos. If you like to proceed, please email me on my email ID, which is mazirules@gmail.com, or you can WhatsApp me on the number of 0097155743474, and I will be guiding you about the subscription process. So thank you so much.